Good evening and welcome to Feet Forward. My name is Chris Martin with the Illinois Podiatric Medical Association. Happy holidays to all of you. Tonight our guest is Dr. Elizabeth Kurtz.
Hello.
Here in Chicago. Welcome to Feet Forward. First time guest, but not first time CAN TV guest, right?
Yes, first time guest on this particular show, but not first time doing this.
Right. And you and I are Facebook friends too. That's how we met, right?
Yes, we are.
That's right. So for all you Facebook friends, and by the way, IPMA is on Facebook, of course. You can find us there at the Illinois Podiatric Medical Association. And we are taking calls all night. So if you have a question for Dr. Kurtz, we're happy to stop everything and answer your question right away. Tell us a little about your practice. You're in the Ukrainian Village, and you're a solo podiatrist, right?
I am, yes.
Okay. Tell me about the kind of patients you see, and so what's a regular day for you?
Well, actually, the type of patient I see anywhere from your baby, so a year or 2 years old, all the way up to 100. So I have a very wide range of practice. It just really depends on the time of day. So in the morning and the afternoon, I generally have my older patients that are coming in for their general foot care. A lot of diabetic patients are in my practice. But I also have an emphasis on sports medicine. I'm an avid marathoner here in Chicago. I've worked at the marathon tent, in the medical tent with Dr. Chin. Well, this year for sure.
Friend of the show, Dr.
Friend
Chin.
of the show, yes.
Dr.
And
Chin,
then also
good
as
friend.
a student. And I've completed 7 marathons on my own, so I like to work with runners in the area as well.
It seems like every podiatrist I have on is like a marathoner. Is that
it's addicting.
Is it like a 4-credit class you get at Shoal?
No, it's not a 4-credit class, but it is something that's definitely addicting and a good stress reliever for us. And a great way to meet patients because you're running behind them and you watch the way that they're running and then you can hand them your business card on the trail. So.
Thank you, Steve. You mentioned that you treat patients up to age 100. You probably don't have a lot of those kinds of patients, but you do probably have a lot of elderly patients. And that's a nice segue into our topic tonight, which is about arthritis. And you had actually talked on the Arthritis Foundation, the Chicago chapter of the Arthritis Foundation's CAN TV show a couple years ago.
Yes, I did.
And our the Feet Forward Scouts actually saw you, and so that's why we invited you to this show.
I saw that I was very personable.
Tonight. It's your hair. It's your hair, to be honest.
Well, you know.
So we want to talk about arthritis and how that impacts patients and kind of how you treat it. So before you get into the details about how you treat it, tell our viewers what arthritis is and sort of some symptoms and risk factors.
Okay. Well, arthritis, most people have heard about arthritis and, everyone's talking about it, especially with the type of weather that we've had out today where it was cold, then it was warm and humid. They may feel like, oh, my arthritis is acting up. But arthritis can happen in any joint of your entire body. It's usually an inflammation or a swelling within the joint itself. It can be in any one single joint or it could be in several joints. Here is actually a model of the foot. And the foot is actually a very complicated biomechanical piece of equipment we have attached to our leg. There's actually 33 joints within the foot itself. So you can understand between 2 feet, you have 66 joints that can be affected by arthritis. So in general, it's an inflammation of either the joint itself or the tissue that surrounds the joint. What was the rest of the question?
Why does arthritis seem to strike the joints, and does it single out feet, or does it sort of reside in the hands, wrists, and elbows, things like that?
It can certainly, as I was saying, it can be in any joint in the body actually, but we tend to feel it in the areas that we have more joints than less. So in the foot where you have the 33 joints, in the hand where you also have several joints, the joints of your body that you're moving around to perform your daily activities is generally where you're actually going to be feeling it, and it always takes place within the joints. It's the inflammation of the joints, the wearing away of the cartilage, which helps to protect the joints. That's what arthritis is defined as being.
Do we know what causes it?
No, not really.
Not really.
Now, this has been much debate and a lot of research. The most common type of arthritis is osteoarthritis or degenerative joint disease. And of the about 40 million people in the country who have arthritis, approximately 27 million have degenerative joint disease. So for that, it's the wear and tear, so your daily lifestyle, if you've had any sort of injury throughout your lifetime, if you've had an overuse type of an injury, that will contribute to possibly developing a degenerative joint disease. But there actually is over 120 different types of arthritis. So some of it is actually based on your genetics. Some of it could be just a type of autoimmune disease that you develop. One of those, the most common that people would know about, is rheumatoid arthritis.
Let me stop you there. We've got a caller now. Not a world record for a Feet Forward, but a pretty good record 5 minutes into the show. So go ahead, you're on Feet Forward. Oh, might have lost him. Oh.
Okay. Guess they
So you're
weren't
talking
very
about
patient.
RA, or rheumatoid arthritis,
Correct.
which is quite a prevalent form of arthritis, right?
It is. It is. Approximately 1.3 million people in the country actually suffer from rheumatoid arthritis. And it's not just patients or people who are over the age of 40. And that's the biggest misconception that I would like to clear up with tonight's broadcast, is that just because you're old doesn't mean you're going to have arthritis, and just because you're young doesn't mean you're going to not have arthritis. So something like rheumatoid arthritis does affect even children as young as 3 and 4 years old. So arthritis is something that truly can happen at any age or stage of life. So
when you get a patient that has symptoms of arthritis, when you're doing your evaluation, what kinds of things do you look for? And take me through kind of a conversation that you have with a typical arthritis patient in your office.
For a typical arthritis patient, keeping track of your symptoms prior to going into the doctor is very, very important. Reasons why you would actually want to either go see your doctor, whether that be your primary care or a podiatrist specifically, you'd be looking for pain or tenderness within either one or several joints within your foot. You'd be looking for any swelling, stiffness, especially in the morning, that sometimes resolves, sometimes does not resolve, but that's important to let your doctor know. If there's any reduced range of motion or reduction in the range of motion with any joint within your foot or even anywhere else on your body, those are things that you want to pay attention to, and also mention to your doctor. Also, if you have any redness or very painful types of sensations coming from around that joint area.
The caller we lost in the air called back and asked that we read this question on the air and see if we can answer it. The caller wanted to know, what is the remedy for dry, cracked feet?
For dry, cracked feet. Well, definitely not a part of arthritis, but but that's okay, because that can also happen with arthritis or any of the medications that you take for arthritis.
Or during the winter when it's dry,
specifically right now. The first thing is making sure that you have good feet or foot hygiene, and so that does involve applying some moisturizing lotion. You can start with some of the over-the-counter types of lotions or foot creams. My favorites, just to mention a few, would be Eucerin cream or an udder balm. The udder balm is the one that they use for, the cow's udder. Helps prevent cracking, so hence...
I didn't know that.
Works very well on the heels.
I thought I knew all there was to know about cows, but...
Apparently not. So, but feet and cows, there is a little bit of a connection there to a certain degree. So trying those over the counter, and you can find them at the drugstore. Even ask your local pharmacist. They may have some formulations behind the counter that's not out there for the general public to see, but they certainly can sell to you because of their degree. If you're not having success with that, then that's the time to make a visit to your physician, podiatrist, to actually get a prescription level type of a cream to help with the fissures or the cracks.
Let's hope we answered that one. We've got another call. Go ahead. You're on Feet Forward.
Yes, my name is Anita. I'm calling about the...
Go ahead.
I have trouble with my feet because I have rheumatoid arthritis. I have a big knot going on the side of my toe. And my arthritis doctor looked at it. She said I don't have gout, but they won't take it off, and I need it taken off. It hurts.
Have you spoken with your rheumatologist about a podiatrist that they could refer you to?
Well, I went to a foot doctor, and the foot doctor had me take, I had to get so many tests, like a heart test. He wouldn't do nothing. He was going to take it off, but he wouldn't do nothing to test. I had all these tests, chest x-ray. I had to get all these tests done. since then, I found out that I had to have an angioplasty. So I don't know if they'll touch me with a 10-foot pole now.
Well, actually, so having this painful knot on your foot actually could have eventually saved your life with all the tests. And those are standard tests that we have to do before we do any surgery on a patient. And that is something that's within the bylaws of the hospital or the surgery center where we're taking our patients. So that's not unusual. And if you look at it from another perspective, if you hadn't gone through all those tests, you may not have discovered that you had a blocked artery. So in the long run, this could definitely have prevented a heart attack for you. Having had that angioplasty, usually we give 6 months to 8 months before we would consider doing an elective type of procedure, which this would be. But just because you've had the angioplasty doesn't mean that you cannot eventually have this particular surgery to remove that knot on the bottom of your foot or on the side of your toe.
Oh, okay.
So just a temporary delay, unfortunately.
Thanks for your call, Anita. All right, we have another call. Go ahead, you're on Feet Forward.
Yes, and good evening. A quick question. I'm a diabetic and have a wonderful team. I mean, really wonderful team. But a question that I always wanted to know was, the podiatrist tells us, never put the cream or nothing between the toes. Mm-hmm. Is it because, it's moisture there, or there's a possibility you could get fungus there? Or do you suggest, is there a cream that you can put in between the toes? But let me just get out there and let me hear your response. And
thank you for your call.
Okay. Well, yes, that is true that we counsel, especially our diabetic patients, but I also counsel all of my patients never to place the moisturizing cream in between their toes. And for exactly the reasons that you stated, it is an inherently moist area of our body because the toes are put together within the shoes and the socks, and having that extra layer of moisture in the cream, that does allow possibly a fungus or a fungal infection to develop. But also because of that additional moisture, it causes the skin to become very delicate, and you could end up with a fissure or a crack in the skin that opens you up to infection. And as a diabetic, we certainly don't want any cracks or openings in the skin that could allow an infection to start. And as far as, are there some creams, there is only one cream that I know of that you can actually apply within the spaces in between your toes. That's also something used for moisturizing. Can I say the name of it?
Sure.
Okay.
Yes.
It is something that you can find online. It's going to be in your local podiatrist office. It's not going to be found in a pharmacy. It's called Amerigel. And it is specifically marketed and meant to be used by patients with diabetes for their unique moisture needs.
Great. All right. Hopefully that helped that caller. Mm-hmm. Let's get this back on track.
Sure.
We're talking about arthritis, and so let's speed ahead in the agenda here and talk about treatments.
Okay.
With the typical arthritis sufferer.
With the typical arthritis, once you're actually, in the doctor's...
wait a minute.
Got
Sorry.
another caller.
Got another call.
So we're popular tonight.
I guess so, yeah. Go ahead, you're on Feet Forward.
Hello?
Hello. Welcome to Feet Forward.
Yes, my question is, I had an ankle fusion in 2001, and now it's starting to bother me really, really a lot. And it seems like it bothers me after I've been on it for a while, and then when I lay down to relax it, if I move any kind of movement, it hurts real bad inside, like I'm sticking or a knife is inside or something. So I don't know what's going on with it. It's been almost 10 years.
Mm-hmm, right.
Ankle fusion?
Ankle fusion.
Okay.
So an ankle fusion, for everyone else who's actually watching, that means that the ankle joint can no longer move, that it's completely stiff. Mm-hmm. After 10 years, there are changes that continually occur in your body. After the ankle fusion, the way that you walk has actually changed as a result of the ankle fusion.
Right.
There's a lot of different factors that can cause the types of pain that you're experiencing, but it's very important for you to, because of the pain that you're experiencing, that's not normal at this stage. Yeah. So following up with either the physician who performed the surgery 10 years ago, if that's possible, or visiting
3 days ago, that's the worst pain I ever had. and I only have one pin in it, but it's not going toward the heel. It's going another way.
Right. And the only way that we can really, figure out what is causing your pain is to actually physically evaluate your ankle. And that would include, in this stage, having x-rays taken to see the changes and make comparisons to what you had. So if you have access to your old records, that would be very important.
Yeah. I had it done, but the doctor, it was in a lot of pain. What he did take the pain away. But he told me I'd be able to walk as far as I want, but it didn't happen. It's a limitation. So, but he did take the pain away, and it don't swell. So, I don't know what's going on. It just seemed to bother me after I've been on it. Then when I lay down and relax, that's when. Then when I get up to move the foot, that's when I have to wait a few minutes before I can. Like if I relax and I get out of a car or something, that's when all the pain is in the heel, and I gotta wait a few minutes, walk about 10 steps or so before I can, carry on.
Right.
Okay. Well, thank you for your call, ma'am. So we're talking about treatments for people with arthritis. So let's pick this up where we left off here.
Well, actually, that call was actually a very good segue into what some of the treatments can be, and surgery can be an option. That's generally the last option. And I'm sure the last patient only arrived at that decision after being in excruciating pain for a long period of time. But it's also a very good indicator, I don't want to say indicator, but not every single surgery is going to alleviate your symptoms 100%. And each surgery is going to have its risks that go along with it. And 10 years and having some pain when you alleviate the worst amount of pain can be considered a success. But there are changes that happen over 10 years. Other things that can happen as far as what we start off with treatment depends on the type of arthritis that we have. Oftentimes in my office, if I've had a younger patient coming in with pain in multiple joints, doing some basic blood tests to alleviate or to eliminate certain types of arthritic conditions that are very common and that would result in a referral to a rheumatologist. I often start off my patients with an anti-inflammatory. Usually they've already been taking ibuprofen or Advil or Aleve at home. So we move on to more of a prescription level type of anti-inflammatory. Sometimes injection is indicated, a steroid injection into the joint that helps to reduce the amount of swelling and inflammation. And also, we are talking about the foot, so trying to change the forces that are going across the foot, and we do that with bracing, with orthotics to help stabilize that foot and prevent that motion from happening across the joint where the pain is actually occurring. Other things that we move on to would be physical therapy, as well as other types of bracing or an ankle foot orthosis, which is actually an orthotic that crosses the ankle joint and further helps to stabilize the foot and the ankle itself.
You brought some examples of a couple pairs of shoes and an orthotic yourself,
I did,
right?
yes, actually. And an orthotic...
I'm sorry, we do have another caller. It's a bonanza here tonight. Hi, welcome to Feet Forward.
I was the one to ask you about the cream lotion between the toes. Another quick question. You just mentioned about the inflammatory medication that y'all guys prescribe, like Etodolac. And the reason why I was prescribed is that I had a knee replacement, played ball all my life, arthritis everywhere. But now I have been told by taking Etodolac so much in a lengthy period of time, it will give that concentration in the urine or in the bladder. So do you suggest, or do you think sometimes you should take it for a lengthy period of time and then just cut it loose? Let me get off again. Let me get out there. So did you understand what I was asking?
Whether or not...
the Etodolac, is it safe to just continuously take this twice a day, 500 milligram? I think it's 500 milligrams. Been taking it now for about 7 years straight, twice a day. Do it have any harm into the urine or the bladder or the kidney?
Well, inherently taking a prescription level medication for a long period of time, it can have some side effects. A lot of the anti-inflammatories, you'll see the side effects either in the heart, so cardiac type of side effects, or actually in the liver, where a lot of those medications are actually broken down before they can be absorbed into our bloodstream and taken to the rest of the body. That is something, though, that needs to be monitored by the physician who prescribed the ketorolac for you.
Well, my endo, not the endo, but my ortho, He's the one that prescribed it, who did the knee replacement. He's no longer there no more.
Okay.
So
well, you can have your primary care physician actually. You can have the primary care physician do some tests, and it's not necessarily a bad idea to consider changing the medication that you've been on. Sometimes your body can build up a tolerance level to medications over a period of time, and if you're still experiencing pain at a significant level, then it may be time to adjust the medication and step up the change or the dose. So.
Okay, thank you for your call. 2 for 1 for you tonight, ma'am. Thank you. So we were talking about the shoes and the orthotics there.
So these are some things that we can actually do in the office, and oftentimes it's just trying to make a patient comfortable, because we want to, with arthritis, you want to continue moving. The worst thing that you can do is sit and do nothing, and there was a point where that's what we counseled patients to do. That time is long gone. Now we want you to get up and we want you to get moving and do activities that you're comfortable doing. And some of the ways that we do that is, this is actually meant for arthritic type of a foot, and what it is, it's 2 layers of cushioning, and it's almost like walking on a cloud. So you're getting the support through the arch, but you're also getting the cushioning to help support your joints and reduce the amount of pressure or impact as your foot continually hits the ground. Approximately most patients or most citizens will walk approximately 10,000 steps a day. If you can imagine your foot hitting the ground 5,000 times, having a little additional cushioning there to help cushion the joints can make a big difference in the amount of pain that you experience or discomfort, the swelling, and also allow you to continue your activities in a more comfortable way.
And when a patient with arthritis comes in, how can you tell from the cast that's made and the evaluation that you do where to put the emphasis on the foot, so that the orthotic relieves certain areas and puts an emphasis on other sort of weight-bearing areas of the foot?
Well, that's something that is part of the evaluation, and then we actually, when I'm doing the plaster cast of the foot for the actual orthotic itself, I put markings on your foot, usually with a magic marker, and most of my patients don't like that, especially in the summer if they're going to be walking outside with sandals, and now they have strange X's and O's. But that's how we communicate to the company who's fabricating the orthotic, where we want additional cushioning, where we want additional support, where we want, and then as part of the prescription, also the types of material that's going to be utilized as well. So.
Great.
Now, oftentimes what happens with arthritis is you end up with very rigid joints in the foot. You end up with either a bunion, which is a growth on the side of the big toe at the big toe joint. We also end up with oftentimes a hammer toe in the lesser toes. The best example is, here's how your toe should look, and here's how it looks when it becomes a hammer toe. And so the very top part of that toe starts to rub on the top part of your shoe. And so another change that we can make is an extra depth shoe. It's generally intended actually for our diabetic patients, but in our arthritic patients, it provides that extra room within the shoe so we don't get that rubbing back and forth. And you can see this is a diabetic shoe.
Yeah. Why don't you hold it up in front of the sign so we can see it a little better?
Oh yeah, it's a little bit dark, isn't it? I apologize.
That's all right. That's all right.
And then I also have a men's shoe, but it's also a dark shoe, so it's
quite
very
fashionable
difficult to see. But these are diabetic shoes. You can see that they're not your grandmother's diabetic shoes any longer.
Very nice.
So.
And how are those? The men's shoe? How do they differ from regular men's shoes? Those look pretty. But most men's shoes are pretty substantive too.
Right.
They're not.
Well, the biggest difference that you'll notice in a diabetic shoe or a shoe that I would, prescribe to my arthritic patients is that they have an increase in height at the toe box.
Give you a little bit more room there.
Yeah. So they give you a little bit more room, bottom to top, so that you're not getting that rubbing, from the top part of the shoe. Yeah. And they tend to be a little bit wider on the inside, and you can't see it here, but they do have some padding on the inside, and then there's no seaming that's there. So there isn't any seaming that's actually rubbing up against any of those bony prominences.
Okay, great.
So.
Well, it's been a great show. Lots of questions tonight.
Yes. You prepared me for no questions.
Well, we always try and cover the whole show because we've got important information to share. But for those of you out there who have a question or need a referral to a podiatrist, go to the IPMA website. That's IPMA.net. Find the physician finder portion of the website. Put in your zip code, and you'll get 2 or 3 referrals of IPMA members, probably in your neighborhood or in your ward if it's a in the city of Chicago or a precinct. You can also call the 800 number, which is right on the screen there. That's 888-869-3338. We hope you have a nice, safe, and healthy holiday. We will see you in the new year.